I'd love to take that opportunity. So today I'm going to talk about OSU sports medicine, but what's it mean for you? You can say, hey, I'm not an elite athlete. I'm not looking for a D1 scholarship. Why do I care about OSU sports medicine, and what's it have to offer me? So my talk's going to be, what is sports medicine as a general concept, and what is sports medicine at Ohio State, and again, and what it means for you. Now, this little video clip was made by one of our postdocs, and they get a kick out of it, and I think other people enjoy kind of seeing this. It just demonstrates again that I've been fortunate enough to work with the Buckeyes the past 26 years, and people say, gee, that's a pretty neat position, that's pretty glamorous, but nothing, those of you out there have any kind of position or title, you realize nothing's quite as glamorous as it may sound or seem. So this video clip kind of exemplifies that.
Is that all you got? I'll take your best shot. Is that all you got? I'll take your best shot. Is that all you got? I'll take your best shot. Is that all you got? I'll take your best shot.
This is us in Iowa. This is our quarterback, Joel Pryor. Every night Friday, here's Terrell. That's me. I go right over the bench. So I'm sitting there, I'm looking up, I see my feet, I see the sky, and I'm kind of turtling there through the bench and the wall, I can't get up. And I'm thinking, oh, gee, the guys should come over and help me out. I'm trapped in there. So what happens, Buckeyes come over, all the players come over, they get Terrell, and they leave me. So again, I'm sitting there, and I'm trapped, I can't get out, I'm sitting there, and my rib hurts, and the fans lean over, and they're like, dude, man, you got blown up, and the fans help pull me out from over the bench. So it's not always glamorous. So what is sports medicine? Well, it's giving medical treatment. And everyone here has got some association, some knowledge, and some familiarity with medicine, different forms of medicine. But it's applying some of those medical concepts in the context of the athlete. What are the priorities of the athlete? What's the psychological condition of the athlete? What's their physical condition? What's the time of the game, time of the season, the time of their career? So you apply these things to an athlete. So this really is personalized care, right? So sports medicine has been doing personalized care for a long, long time. The last decade or so, we're trying to apply that concept more and more to every subspecialty within sports medicine. And it's important to realize for the athletes, these elite athletes, how much time and energy they put into being a high-performing athlete. In fact, they define themselves as an athlete, and performance defines them as an athlete, which defines them as an individual. An example of that is, I've had this happen to me 2 times. We're on the sideline of a football game, and the way we do things here at Ohio State, if an athlete goes down, the trainers go out and assess the athlete that's down, and the docs, there's 3 of us, we stand right here at the 90 degrees at the sideline. And at this particular case I'm thinking about, they helped the athlete up, got tangled up, went down, laid there, the trainers run out, they go to a TV timeout, they walk him over, and typically we kind of walk out and talk to the trainer, what do you think? And the trainer will say, his finger's out, or whatever, something happened. And they say, we don't know, he's hysterical, we can't make any sense of it. And the kid's having a panic attack. And we're sitting there, settle him down, finally he settles down, he says, I blew out my knee, and he starts crying and sobbing, I blew out my knee. And we take a look at the knee, and it's just a little tender here, we find it's just got a little grade 2 MCL sprain. And the kid settles down. Am I okay? I'm okay. Yeah, you're okay. You're okay. Just your injury's going to be fine. You're going to be, a couple of weeks. You're going to be back. You're going to be fine. And they finally settle down, and they say, Doc, you sure it's going to be fine? Yeah. He goes, well, I heard a pop. I thought I blew out my knee, and I saw my life flash before my eyes. So think about that near-death experience. I saw my life flash before my eyes. To them, pop, blowing out knee, I'm no longer an athlete. To no longer be an athlete was a near-death experience for them. So twice I've heard an athlete tell me that my life flashed before my eyes when I had this injury. So it tells you how important it is to them to be able to perform. Now, that may not apply to people in this room, but just to let you know that it's the context of the athlete. So in sports medicine, we can give suboptimal care to an injury, suboptimal care to an injury in order to give optimal care to the athlete as a whole. All right, now you may say, well, wait a minute, here at Ohio State, we don't give the best treatment to our athletes? Well, I'm going to give an example of this because I don't want to be misunderstood. What's the optimal treatment for an ankle sprain? Okay, you roll your ankle, you feel a pop, it swells up. An ankle sprain is a tearing of a ligament. the optimal treatment for that injury, that ligament takes 6 or 8 weeks to heal. Protect it, don't retweak it, protect it for 6, 8 weeks. Now you need 6 or 8 weeks of some neuromuscular rehab, functional rehabilitation to get them back to play, right? Are you going to tell an athlete, a basketball player in mid-season, oh, you sprained your ankle, oh, you're out for 3, 4 months? Well, the ideal treatment for that ankle is to put them out for 3, 4 months. But we give suboptimal care to the injury in order to give optimal care to the individual, the patient as a whole. Again, personalized health. The challenge of doing that is we can alter the injury treatment to benefit the individual as a whole. All right, my example, the basketball player mid-season with an ankle sprain. But we must never risk the individual as a whole just to return an individual to competition. So if we are going to compromise optimal care of an injury, we can never do it in such a way that we put that individual at risk for additional injury, more severe injury, or long-term disability. And this can be a gray zone, and some of my colleagues in medicine, we've, I think in the past, strayed too far into that gray zone, but that's a subtlety and just an example of personalizing medical care for athletes. So what's interesting in sports medicine, I enjoy this, is it's not always fun, but both the clinician and the patient function in the competitive arena of athletics. We're always being pushed to how we can do things better. The athlete's being pushed how they can do things better. The medical team is. And over at Woody Hayes, and if Urban Meyer were here, Coach Meyer would readily say, yes, absolutely. I don't want anyone comfortable. I want everyone pushing harder to be better at what they do. And that includes the strength conditioning staff, the recruiting staff, and the medical staff. He'd always say, Doc, is there a better way to treat a high ankle sprain? What's the latest on that? I don't want to hear we're doing it the same way next year as we did last year. Something's changed, something's got better. How can we do it better? So we want to take these injured athletes and allow them to get back as soon as possible to as high a level of function as possible and as safely as possible. So some of these lessons that we learn by being pushed in the competitive arena, we can then apply to the weekend warrior, to the people in this room. And I can give numerous examples. I don't have to go through this whole story about MCL injuries, but we used to think that MCL sprains, grade 3s, couldn't play. You had to put them at rest. That was a 6 to 8 week recovery minimum. We now realize that's not always the case. Depending on how the shape of the leg, if the athlete's a little more bow-legged, they actually can play and perform with an MCL injury, and that's led to this concept of functional treatment of an MCL. So if you come to me and you have a grade 2 or 3 MCL sprain, because of what we learn on the field, I don't have to necessarily put you in this big brace or cast, which is what we did 20 years ago. So what is sports medicine? Personalizing the injury treatment. We just talked about that. Medical issues, concussion, asthma, etc. Team management, drug testing, nutrition status, injury prevention programs, trying to prevent hamstring strains, ACL tears. What about rehabilitation, trying to get them to recover and return to play in as fast and as safe and optimal situation as possible? What about risk assessment, pre-participation evaluations? When someone comes in before they perform, we need to assess are they at risk? Is it safe for them to perform? In fact, arguably, you can say that's the number one responsibility of a team physician of clearing and deciding if and when an athlete can return to practice or play. And the NCAA is very good about that, saying the team physician has indisputable authority to make that call. And what about performance enhancement? What can we do to help them perform better? So these are traditional last 40 years or so. That's what sports medicine has been about. So a very traditional view. But here at Ohio State, we've altered that view. We've expanded the scope of that concept. And we feel that sports medicine is not just for the elite athlete, but for the athlete in all of us. A little bit of a trite cliche, but it really gets the concept across. Sports medicine is for all of us. The mission statement for OSU Sports Medicine is to improve people's lives by enhancing physical activity across the lifespan. All right? So if you are a coach of a youth girls soccer program and you want to try to prevent ACL tears, we're here for you. If you're the high school athlete that tore their ACL, we're here for you. If you're the patient that's got recurrent concussions, you've got asthma issues, you're the senior who's trying to stay active, which is going to be the point we're going to talk more about today, we're here for you. So Hippocrates, over 2,000 years ago, said, eating alone will not keep a man well. He must also take exercise. For food and exercise, while possessing opposite qualities, work together to produce health. Eat well, exercise. 2,000 years ago they were saying that. You see your doctor today charges you $20 and says, hey, eat well and exercise. So Nothing new, but very, very basic and very true. So exercise as medicine, or exercise is medicine. When I say medicine, I'm talking about like a medication, okay? People are always saying, gee, I wish there's a pill to solve my problem. All right, that's what people want. Is there a drug or a pill I can take to solve this particular problem? We know there are tremendous health benefits that can be achieved with either low levels of exercise. I'm going to come back to that. The amount of exercise required. We'll talk about the different types of exercise and activity. The amount of exercise needed to benefit health is much lower than the amount needed for fitness. Okay, we're going to come back to this concept, this line right here. So some of you in this room will say, gee, I'm not an athlete. I never was an athlete. I'm not going to sit there and start doing these workouts I see him do at Woody Hayes. You don't need to. In fact, you probably shouldn't. So we know, and this slide's key, this is kind of a take-home slide, regular physical exercise at the correct intensity, we'll talk about duration, frequency, and intensity, can reduce the risk of heart disease by 48%. Think about that. People in this room, in fact, we're in a heart hospital. You all have family or friends who've had some kind of cardiac issue. Regular physical activity can decrease your risk of cardiac issues significantly. What about stroke? You guys have had, I'm sure you've had friends or family touched by stroke. Decreased stroke, 27%, that's impressive. Incidence of diabetes, 50%, no question. Type 2 diabetes is rampant in the U.S. Exercising is one of the best things we can do to help control type 2. The incidence of high blood pressure, almost by 50%. Mortality of recurrent breast cancer, think about that. We're right next to the James Cancer Hospital. Studies have shown, decent quality studies have shown that decrease the risk of recurrent breast cancer by routine exercise. Lower the risk of colon cancer. Reduce the risk of Alzheimer's disease. And we'll talk more about the benefits to the brain with routine exercising. How about depression? It's been shown to be very effective as well. So if we had a pill that did all that, think about that, that last slide, I'm going to back it up. If I had a pill that did all this, you'd be taking that pill every day, wouldn't you? I'll take that pill, sign me up. So if we had a pill that did all those benefits and was readily available, we'd make a darn sure way that every patient took it. So Bob Salas, he made that comment. He's the one who coined the phrase that exercise is a medication, is a drug. It's medicine. And you say, well, what's the risk? All medicines, all drugs have some kind of downside. They all have side effects. Well, really, this prescription, this drug is physical activity, and the risk, the little black box, is minimal side effects. You can get overuse injuries. Well, start low and go slow. Don't go out there and go too much too soon. This is common sense. Most of this talk I'm giving you is really kind of common sense. It's nothing earth-shattering here. I'm hopefully just nudging you guys along to act on what you intuitively know. How about sudden death? Sudden death is very rare. In fact, you can make the argument that if you go low and go slow, the risk of sudden death is actually lower. So physical activity is the prescription. How do we get people to stay active? Lauren and the Healthy initiative here is all about motivating and helping people to be active. We all know we should do it. So exercise is medicine. We know the mitochondria in your cells, that's the powerhouse of the cell. As we age, the mitochondria don't work as well. You may notice you can't quite generate the same power you did, the energy, work intensity, or energy level. But resistance training in the muscles, resistance training means pushing some weights around. So my mother's 89 years old, and about 15 years ago, I got her to go to the YMCA, and she started pushing weights around. Now, my mother is only about this tall, and she is not pushing very big weights, but she's pushing a weight. And the fact that she's doing some resistance training is very good to her, very good for her, because this can reverse this trend in the muscles, and it's called sarcopenia. Everyone's aware of osteopenia. That's been around for 40 years. As we get older, we start losing bone mass, more impressive in women after they lose estrogen after menopause. And this causes all kinds of hip fractures and Colles fractures, Pachyhumerus fractures. A big problem for society, big medical expense to society, big burden to society. So how do we prevent osteoporosis? And that's been a big push, and I think most people in the room understand that we need to work and try to avoid osteoporosis. A complementary concept is muscle weakness. So how do we avoid muscle weakness as we age? Very analogous, and that occurs in both males and females, and exercise can minimize the sarcopenia. Sarcopenia means your muscles are getting weaker. Osteopenia, bone, sarcopenia, muscle. More and more evidence when I look at sarcopenia and muscles getting smaller and weaker as you age has a negative impact on your quality of your life. So we need to avoid sarcopenia. So 150 minutes a week of moderate intensity physical activity. If you just want real quick, down and dirty, 30 seconds, hey, how much exercise should I do? Well, if you can do 30 minutes of moderate intensity 5 days a week, or 3 10-minute sessions per day for 5 days a week, that does it. Not overly demanding. The intensity, we talk about 50 to 70% of your maximum heart rate. Your maximum heart rate is 220 minus your age. So if you're 55, your target heart rate's right around 90 to 100. Now, I like to use the term conversational. You're not going to do it if it's miserable. If you're sitting there and you overdo it and you're exhausting, you're panting, and your heart's racing, you barely breathe, and you look at your watch, I've been doing it for 3 minits. Holy cow, Dr. King said I got to do 30 minutes of this? You're just not going to do it. You're going to say, forget it, I'll die 10 years earlier, I don't care. So if you only need a level of intensity to have at a conversational rate, meaning get your heart rate up a little bit, you're breathing just a little heavier, but you can carry on a conversation. That's the intensity of exercise or activity you need. All right? It doesn't have to be hard than that. It's very modest. It can be a brisk walk with your girlfriend. That's the key. Well, if you're a guy married, you may watch out for that. But anyway, so conversational level, okay? So that makes it very acceptable. So I'm going to talk a little bit more here in a minute about what does exercise mean. I think some people may misunderstand the therapeutic level of exercise that we need. So you can talk, but maybe you can't sing, all right? So that's if you don't want to sit there and have a calculator calculate your maximum heart rate and heart rate and check your pulse and all this, a nice easy thing to do is, hey, you got increased breathing, but you can talk, but you're not breathing so hard you can't sing. I mean, you're breathing hard enough that you can't sing. Nice little guideline. So summary, evidence is overwhelming of the health benefit of physical activity. We want to keep everyone active. Okay, back to OSU Sports Medicine. Our mission is to care for the entire spectrum of human activity, from the elite athlete to someone who says, I've never been an athlete and I'm 50 pounds overweight and I'm 58 years old. I need to start to get fit. We are there to help you. So OSU Sports Medicine, we underwent a major organizational change back in late 2004. One thing we are here to, if there's one thing Ohio State is, we're big, right? We all know big, we know bureaucracy. But with big comes this breadth of expertise. And we made a decision that we'd create a true center, academically neutral. A center at a university means something. It means our program is not one department, all right? So universities have colleges, colleges have departments, departments have divisions, divisions have sections, very traditional militaristic hierarchy. Why would the president of a university or dean of a college want to have a center? Well, they want centers because they want to build positive synergies and collaborations between these traditional siloed departments and divisions. So that's what we did. Multidisciplinary, we're committed to enhance every entity we touch. OSU Sports Medicine. In these entities that we interact with, we want to make that entity better. So it's playing to our strength. Again, if there's one thing Ohio State is, it's big. We have a large amount of breadth of expertise. Let's bring these expertise areas that touch sports medicine under the umbrella of OSU Sports Medicine. So we have 15 different disciplines that practice, quote unquote, sports medicine at the James and Crane Sports Medicine Institute off Ackerman Road. So, and this is just a slide I'd like to point out, since we started the center, we have formal interactions with all these different entities within the university and even outside the university. Very exciting. Studies have shown that staff and faculty actually have less burnout in their job if they have trans or interdisciplinary interaction. If you're whatever, an XYZ, and only deal with other XYZ specialists, at some point it can get a little intense. But when you start to stretch out and see the ABCs or the MDFs, whatever, you start seeing other people. That's kind of fun. It's kind of stimulating. People enjoy that. Nice professional environment. So what about our footprint? 2004, we made the change. We pretty much OSU Sports Medicine one site, then in 06, 11, and then 16. So you can't hide. You guys all live in Central Ohio. We are not far from you, okay? You can find us. So our visits, our numbers just keep going up. Our organization, very proud of this. So we've taken that concept of multidisciplinary centers, getting out of these strictly defined silos, and developed these multidisciplinary clinical teams. And this clinical team, we'll talk about these teams in a minute, we have orthopedic surgeons, we have sports medicine non-operative physicians, we have physical therapists, athletic trainers, research assistants, PhD, basic scientists, we have masters in public health, all these people all working together on this team, and you couple this multidisciplinary clinical team, and it leads itself right to research and education program. We have a hip preservation team. We have 2 orthopedic surgeons who like to do hip arthroscopy. We have 2 non-operative sports medicine physicians who like to do ultrasound-guided assessments and treatments. We have a PT, PhD, who's very interested in making her mark on clinical outcomes after hip arthroscopy. At each of our 7 sites, we do physical therapy. We have a lead therapist that has a special interest in hip rehab. So that team, the hip team, meets once a month, and they talk about treatment algorithm, how do we get the patient to the right person, and maybe they're seeing the non-operative physician who sends them to therapy, but when should they come back? When do they get back to the surgeon to discuss maybe they do need a scope? And how do we get maximum efficient care of the patient? This lends itself to, I think, efficient patient care. It lends itself to a group getting together, asking questions and how we can do it better so we stay on the leading edge. It lends itself to data collection and doing research. So it's all very proud of that, and we've had great success on it. So our multidisciplinary programs, and there's more than these. So I talked about our hip preservation program. We have an ACL prevention program. We have a dance medicine program. We take care of Ballet Met and the School of Dance here at Ohio State. So you here who like to dance, or were dancers, want to continue to be dancers, or have daughters or sons who dance, and they have dance issues, we have a team, and they were prior dancers, who understand the world the dancers live in. In fact, the Crane has a bar and a little mini dance studio where so the dancers come in and be evaluated in their home environment. We just hired a 3rd sports psychologist. People sometimes have issues with either the elite athlete may have issues with dealing with, just got hurt and they're angry, they're frustrated, they're depressed, or returning, they're tentative and they're nervous, they won't get re-hurt, and we have to get them back to participate. There's family issues when someone gets injured, or it's someone who's, I need to go to exercise, but I'm overweight and I'm so embarrassed by this. We have a psychologist talking about the fact, you know what, up here you need to start exercising, but because you're overweight, you're too embarrassed about it, they help them get through that barrier so they do start to exercise. So sports psych. We have a runner's clinic, a cycling clinic, sports nutrition. We're expanding our sports nutrition program, concussion. We even have some therapists who like to lift weights. So if you have certain ailments and issues, because you like to do resistance training, we have people who specialize in the issues about lifting weights. Golf performance, we can do the motion capture analysis of your swing, not to necessarily help keep your ball in the fairway, but to identify patterns in your swing that put you at risk for injury. And the throwing head athlete, and then this is something we knew we're starting. It's a surprising number of tactical people, everything from the firefighters to the state troopers to the city policemen to the FBI to all these Homeland Security, all these people that work in these agencies, they have certain physical needs and demands, and they start to get older, right? It's one thing, all these tactical guys, when they're 25 or 30 or 35, or women too, they start to have issues when they're 45, 55, or 60, so we have some specialists who understand what they need to do and help get them back to that. So these multidisciplinary programs, very proud of these, and this exemplifies that concept that we're a center, multidisciplinary, collaborative. Clinical. So,
the case was a routine repair of an injured knee ligament. The event was anything but routine. As he performed surgery at the Ohio State...
Let me keep going. So we were the first ones to do surgery using the Google Glass. Very interesting. Real quick on that. When they debriefed afterwards, the Google people were asking me, what's it like to wear Google Glass? What struck me is Google Glass, and they took them back, they're modifying, they'll come out. This technology is going to be there. There's going to be a time in my life where everyone's going to have these in their glasses, the glass frames. You wear these things, and hands-free, you can send video, send audio, receive video, receive audio. So I can be in the middle of surgery, and by speaking, I can send with the camera what I'm looking at to my partner or associate across the city, across the country, and say, hey, Jerry, I'm looking at this. What do you think? What do you think about this? And Jerry can look at it and give me some advice, or you can say, hey, I'm going to send you an image of what I did with that. Next thing you know, I look up here, and it's like looking in a rearview mirror of your car. A little image over here. Now I'm seeing an image he sent me. I'm in the middle of surgery. My hands are in the middle of whatever. I'm doing all that hands-free. What about the use of that for in the military? In the mountains of Afghanistan, and someone's wounded, the paramedic now can sit there, and once he's connected to a network, he can be the eyes, ears, hands of a specialist thousands of miles away to care for that wounded person. What about rural America? In the middle of nowhere, the first responder now can. So we were one of the first ones to do that, and we've pushed Google to start to expand that. Artificial meniscus, starting to restore cartilage, regrow cartilage in knees. We developed a better way to do Achilles tendon repairs, the Google Glass we talked about. So very proud of the innovations we're doing. And the biggest area we're doing in some of our industry trials and innovation is the arthritic knee. And I'll bet dinner there's 1 or 2 arthritic knees here in this room. So we're expanding our clinical trials on what can we do to help people stay active when they have arthritis in the knee. Because arthritis is an issue. We don't have a cure for it, but there's a lot of interest. Industry is very interested, pharmaceutical and orthopedic companies are very interested in trying to find a better way to treat arthritis because it's a huge market. So this is where the marketplace works in our favor, where they want to help work with institutions like us to help find ways to alleviate the symptoms or modify the disease of arthritis. So these are all the institutions we collaborate outside the university. These are some of the research awards. And we need to update this slide, but we continue to win numerous awards. Again, I think by putting together this framework of collaboration between the disciplines, that's when good things start to happen. How about our outreach program? We work with the USA Rugby. Rugby Sevens, for those who know about rugby, Olympic sport last year. The athletic trainer for the U.S., the American Eagles, was an Ohio State trainer. We work with the Columbus Clippers. So I think 17 of the players in the World Series roster had been in Columbus with the Columbus Clippers. The Columbus City Schools, the All Machine, Ballet Med, Columbus State, Capitol, Special Olympics. Really enjoy working with the Special Olympics. They need obviously some additional help with their screenings and whatnot. Work with Upper Arlington, Olentangy, kind of goes on and on. So high school, collegiate, professional, different clubs and organizations. This slide was not much more than just Ohio State back in 2004. So a lot of expanse and growth. We have physicians at 5 sites, physical therapists at 7 sites. We have 85 physical therapists. So great big program. All right, again, okay, that's what we should sports medicine. Be sitting there, okay, that's good. Okay, that's good, Dr. K, that's great, but what's that do for me? Well, again, you've got the point. Whether you need surgery because you've torn an ACL, you have a pothole on your articular cartilage in your joint, you need to have new cartilage created. Whether you're having recurrent back pain because you like to play golf, you've got a hip that you're worried about, you want to do something to avoid having a total hip replacement, you're the weekend warrior, you're the coach of a youth team, and you want to try to prevent this epidemic ACL injuries in young female cutting sport athletes, you're trying to manage some arthritis, you've got someone in your family who loves to be active but they're dealing with asthma issues, concussion issues. Concussion's huge. We can talk a lot about that. You're the active senior. The biggest demographic that we see at OSU Sports Medicine is that patient between the ages of 40 and 70 who wants to stay active or start to become active, and they've got various issues of aging that they're dealing with. That's the biggest demographic we have, is actually this one. So enhancing and promoting physical activity throughout the lifespan, that's OSU Sports Medicine. Whatever the problem, whatever your age, we want to be there to assist and be a resource for you. Now, I like this. I'm a bit of a science history buff. Sir Isaac Newton, his first law of motion was a body at rest tends to stay at rest, and a body in motion tends to stay in motion. So let's get our bodies moving, because then we can help keep them moving. So let's talk about bodies in movement. Exercise, activity, and training. Some of you people may think, those 3 words mean the same thing. They really don't. There's a distinction between those 3 concepts. I want to kind of go through those. So activity is just movement during the course of your daily living. Okay, that's activity. That's how we interpret activity in this context. So it can be gardening. Nice example. So we encourage an active lifestyle. Now, if you have an active lifestyle and you like to garden, that's being active. Is that an exercise program? No. Is it a value? Yes. So that's activity, active lifestyle. Exercise. Exercise is a planned, structured, repetitive entity that's specifically done for health benefits. Right? You go out to exercise, you go for a nice power walk, you're doing it for health benefits. It might be mental health, I feel better, it might be stress management, whatever it is, but you're doing it for health benefits. Training is exercise and practice with the goal of increasing performance. You want to perform better. I want to run faster, jump higher, be a better volleyball player, softball player, football player, whatever it is. So this is what a lot of people think, when the doctor says you need to start an exercise program, a lot of people think it's this. They think, I'm not doing that. No, that's not what we need you to do. We need to get back to that conversational level of exercise, 150 minutes a week. So exercise, activity, and training, don't lump those into one. So we want exercise and activity. We want you to exercise 150 minutes a week and pursue an active lifestyle. Again, tremendous health benefits achieved even with low levels of exercise. Now, those low levels of exercise, your performance may not go up. All right, if you're 62 years old and you go for 150 minutes of walking with your girlfriend every morning, you get your heart rate up a little bit and you're kind of huffing and puffing a little bit going in there, you're not going to be an Olympian doing that. But you don't need to, you still get the benefit. All right, so that slide, I want to hit that again and again with the crowd because some people psychologically have a hard time dealing with that. So 150 minutes a week, 30-minute session, 5 days a week, conversational level of exertion. This level, we're not train you to high performance, but we'll give you the health benefits. What about age and exercise? Exercise, clearly, this isn't just a cliche, intuition. Studies have shown exercise is beneficial at all ages. As we age, a lot of people saying, depending on which benefit you're looking at, the benefit actually increases. It's easy to exercise when you're young. It's more important to exercise as you get older. It's never too late to start. That's been documented in numerous studies. A Swedish study said that physical activity was the #1 contributor to life longevity. Mayo Clinic just had a study showing that these cells actually, at any age, will respond in a positive way to exercise. The cells in someone who's older who hasn't exercised actually respond more when you start an exercise program than someone who's young. So it's never too late. Now, we talked about the benefit of exercise on that 20 minutes ago, but specific to seniors, old man time puts another 10 pounds on us every decade, right? We've all seen that. Every decade you go, you tend to get 10 pounds heavier. And sometimes you kind of lose control of your appetite. You either don't have an appetite, not enough appetite, or too much appetite. Exercise can help control your weight and your appetite, help regulate your sleep. That becomes an issue as you get older, right? Sleep regulation is better when you exercise. Mood and self-confidence. You start working with the elderly, they can sometimes lose their self-confidence, you get a little depressed. Mood is benefited in the seniors. And then here's the biggest one. More and more studies are looking at this. Most recent study was after 6 months of routine exercise in an older population, no question, their memory and cognitive ability improved. So brain function is benefited in seniors by exercise. So enough said. You said, Dr. Cato, okay, exercise, what do you mean? What kind of exercise? Well, they kind of fall into 4 categories, and I'd encourage you to kind of look at all 4. One is balance, okay? When you're young, high schoolers probably don't need to work too much on this, but as you get older, you need to work on balance. Tai Chi, yoga, working on your core, these different, working on the, that balance ball, that little half sphere rubbery thing you see in all the gyms. Very important. As we get older, we lose our sense of balance. I always tell my patients, we're looking at neuromuscular maximization, not just muscular strength, it's neuro. Your muscles may be strong, but they don't fire at the right little millisecond. That's when you start to lose your balance, so work on that. Cardio, aerobic. This gets your heart rate up and you increase your breathing. To do that, you typically have to use large muscles, and it's usually some kind of repetitive motion. You bounce around doing the same thing over again with large muscles, get your heart rate up, you breathe heavier. So that's cardio exercise, aerobics. Strength exercise. This is all about building muscles, making your muscles stronger. Repetitive motions against some kind of resistance. It could be a body weight, it could be a rubber band, it could be a barbell, it could be a machine, something. Now, up to about 10 years ago, I think most people were focusing on balance and cardio, and the fourth one is flexibility. Again, sarcopenia. As we get older, your strength may not be great, but you need to do some resistance training, minimize your wasting and weakness of your muscles as you age. And then flexibility obviously decreases age, so you work on that. Some balance of all 4 of those. You may push one more than the other, your personal bias. That's fine. Find something you enjoy to make sure you do it. That's the bottom line, you got to do it. So I tell my patients all the time, if it's a miserable experience and you don't enjoy it, don't get a sense of a reward from it, you're not going to stick with it. So find some combination that works for you. What about some of the myths of age and exercise? There's no point in exercising. It's not going to stop me from getting older, right? I'm going to get old anyway. Why exercise? Well, we just talked about that. The symptoms and negative consequences of ages will be less. Chronologically, yeah, when you go from 81 to 82, that's not going to change. But if you exercise, you may be 82, maybe you feel like you're only 76. You're going to feel better. It's too frustrating. I'll never be the athlete I once was. Well, that's true, but it's not. Being an athlete is about performance. I talked about it. Sports medicine is about performance. The exercise we're talking about here has nothing to do with performance. It's all about the health benefit. So don't get hung up on, this is more of a guy thing. It's frustrating. I used to be able to do that and I can't do that anymore. Well, you're not looking at performance. I'm too old to start exercising. We talked about that. That's a myth. I have too many aches and pains. Well, I'll tell you what, if you want to get some of those aches and pains to diminish in their severity and want to decrease the amount that they'll progress in the future, exercise with all its indirect benefits will help that. I was never an athlete when I was young. Why start now? I see that. I was a lousy athlete when I was a kid. Why should I do it now? We're not doing it about being an athlete. We're not talking about performance. We're talking about your health benefit. What about your excuses, all right? I'm too busy. Well, we live in a very busy society. The key is you have to understand, as part of my talk today, you have to prioritize. This is a value. Prioritize it, get into some kind of routine, make it a habit. You have to schedule it. It has to be in a routine. If you just kind of fit it in here and there, it's not going to happen, right? Because you're all too busy, things pop up all the time. I'm too old. We talked about that. That's nonsense. I'm too fat. Well, it's even more important if you're fat, if you're overweight, and the vast majority of Americans are. Start slow, and this is key, I think. Find a comfortable environment, all right? A lot of people are heavy or embarrassed going to the gym. You got Mr. Muscle there doing all this stuff, and all these beautiful young ladies doing this stuff, and you're like, gee, I'm heavy, I'm embarrassed. No, find a group of people, partner, an environment that you're comfortable so you can start your program. Don't let that excuse, oh, I'm fat, I'm embarrassed, I'm not an athlete, what am I doing here? It's not for me. That's an excuse that you need to avoid. It's boring. Well, you're right, a lot of aerobic stuff is boring. It's repetitive, getting your heart rate up. Somehow make it social. I've used a couple times the example of go walking with a girlfriend. Do something where you can chat. Make it social. Maybe it's a group you commit to meet and go to this gym and this fitness center, everything. Maybe it's a spinning class, whatever it might be. You can watch videos, TV shows anymore, all that stuff. You can listen to books on tape, listen to music. You can vary what you do. You can think of what you enjoy doing to distract you a little bit from the tedium of the exercise program. So it's boring. You can address that individually if you just make the effort. It's an excuse. I have arthritis. We talked about that. If you customize the plan to deal with the arthritic joint, it can actually reduce your symptoms and progression of your arthritis. It's actually a treatment for arthritis, is to exercise. Because I'm already skinny. Look at me. I've always been skinny. I'm blessed. My parents were skinny. I'm skinny. Why should I exercise? Thin is good, but it's not sufficient. All right, I'm going to expand on this one a little bit. So look at this slide here. Yellow is fit, purple is unfit. Here's someone who's lean and how healthy they are. Normal, obese, thin. In every case, you look at the control for morbidity and death and the control for age, smoking, alcohol, and family history, that being fit, even if you're lean, normal, or obese, is more important than your body weight. Another example here. Fitness level. Low, moderate, or high, BMI, thin, normal, heavy. In every case, you can see being fit is more important than being thin. So I don't want to overstate this. I don't want you guys going out there and I've been there saying being fit and fat is actually better than being skinny and unfit. Now I say fat, 20 pounds over. You're better off working out and being fit, exercising, carrying an extra 20 pounds than starving yourself to be skinny and never exercising. There's a term, skinny on the outside, fat on the inside. You can carry fat around your heart, things inside your body. So just being thin, that's my next point down here, skinny does not equal healthy. That's good, not being heavy is a good thing, but that in and of itself is not sufficient. Being unfit is a greater risk than being moderately overweight. Not morbidly obese, but just a little overweight is okay. So don't get too hung up on just thinking the goal is to get your percent body fat down. So I don't want you to walk out there saying, Dr. Kane said I can go out and be fat, but realize being thin in of itself is not the goal. Now, the other time, let's not overemphasize fitness. Now, this is kind of a fine point. Being fit doesn't mean health either. This hit me about 4 years ago. We had the Navy SEAL team here with their medical team. And I made the statement to one of the medical team members. I said, gee, it must be nice to work with such a healthy cohort of patients, a healthy cohort. And they corrected me right away. They said, whoa, Dr. Kading, these guys are fit and they're capable. They are not healthy. Not healthy, yeah. they're sleep deprived, they're overstressed, we send them over. These are active special operators. We send them over 3 months back and forth to Afghanistan. They go off 36-hour missions. They don't eat. They're sleep deprived. They're under stress. Their cortisol, stress hormone levels high. The testosterone levels low. Chronic stress in a male will drop testosterone. Having low testosterone is not a good thing to try to avoid injuries. So this is not a healthy lifestyle. But you look at them, yeah, you can drop them out of an airplane. They'll swim for a mile, climb 2 mountains, and do some risky thing while under hostile conditions. Very fit, very capable. They're not healthy. Interesting concept that struck me. So clearly, diet's important, your sleep's important, stress management's important, social interaction is important, and finding some meaningful purpose to your life is important. You talk about people live long, that's a common theme. People live long, they somehow have something worthwhile they feel that they're living for. So we know that good health, again, diet, sleep, stress management, social interaction, purpose, exercise, all contribute to good health. I'm going to make the argument, and this has been documented by science, that exercise is one of these, but exercise also enhances your sleep patterns, your stress management, and can help regulate appetite. So exercise has even an additional benefit to all these factors that go into good health. So keep moving. And OSU Sports Medicine is here to help you keep moving. Good luck. Go Bucks. Thanks.
Thank you. I have 2 quick announcements before we take questions. So we have the lovely Dixie Beal out here that is doing biometric screening. So if you haven't gotten your biometric screening done, she'll be out here until about 2:30, and she has plenty of free appointments. So just stop by and see her. Your evaluations. Everyone should, for the most part, have an evaluation on their chair. If you don't, please just kind of look around you, see if there's an open seat, and you can grab the evaluation off of that one. We take it into consideration. In fact, I'm going to give all the feedback to Dr. Kading right here. So he would really appreciate your feedback on the talk. So we do take them into consideration. We do take your ideas into consideration. So please fill them out. All right? Questions? If you can raise your hand, we'll come around with the microphones. Don't be shy. Back here. All right. Oop, hold on here.
Thank you. A quick question. Even if you're just fast walking, is there a difference between blacktop surfaces and, natural ground or light, gravel, like in a park setting versus on a road setting or something?
So the question is about the surface on which you're walking if you're going out for like a brisk walk, a power walk, getting out there for exercise. And I think that is a great exercise. You burn as many calories walking a mile as running a mile. Now, you don't quite get the cardiac workout, but you burn the same amount of calories. So when we walk, every time we take a step, every time I take a step, if I put you on a force plate and put you through a motion analysis, every time there's a step, there's a little peak ground reaction force, a little peak stress that is absorbed by the foot up through the pelvis to the spine. Now, you want to make sure that repetitive force that's being transmitted up through the lower extremity is handled and absorbed in an appropriate way. If you have some abnormality where that you have a peak force or load concentration, you're setting yourself up for a stress fracture, a bursitis, a tendonitis. All right. So, and as we get older, our feet tend to change, right? You don't have as good a looking and supple a foot now as you had when you were 13 or 14 years old. So with your foot, you may need a special shoe or an orthotic, depending on the deformity of a foot, if you have a bunion or some kind of bony prominence, or if you have some arthritic areas in the ankle or in the midfoot. Those may require maybe a special shoe or something to help make sure the forces are dissipated well. Now, another way to dissipate force, some things I just talked about now are the mechanical, to make sure that the force doesn't get hit in one spot that causes injury, pain, and damage. Another way is to dissipate the force is to have strong muscles. I don't know if you've noticed this, that if you have let's say you have a knee that's got some arthritis in it, and your muscles are weak because you haven't exercised and done much of anything, haven't even lived an active lifestyle. You say, gee, I'm going to start walking. And you start, I'm going to go out there, by God, I'm going to do an hour and a half walk around the neighborhood here, and I haven't done it in 10 years, but I'm going to go do it. You do it and you say, man, I did that 2 days in a row. Man, my knee's sore. This arthritic knee hurts. If you get your quadriceps and your core stronger, I can almost guarantee you that that amount of soreness that your arthritic knee has when you walk will go down. Because what muscles do, muscles act as energy absorbers or force energy dissipators. It's like a shock absorber. So that's another reason you want to avoid sarcopenia. Muscles protect bones and joints. All right? I always talk about Eddie George, very blessed individual, great musculature. And these athletes, if they anticipate the blow, Eddie George's hip can take 100 units of load and not break his hip. Your grandmother just kind of takes a little step, boop, broke her hip. Well, yeah, her bone's weaker, but not only are her bones weaker, her muscles around her hip are much, much weaker, and the neurologic system is impaired. So whatever muscle she did have in the hip didn't fire. So he took that little step. When Eddie George does this joint and gets this 1,000 pounds of people falling on the hip, he's got all these muscles firing to take that energy and dissipate it, spread it all over his skeletal system. Grandma took this little step, and all that load, although it was lesser load, all that load went to one little spot. Where Eddie George had it spread over that one little spot, boom, broke the hip. So the concept there is that a maximally functioning neuromuscular system, muscles that are strong, have good endurance, and are good balance and proprioception, position sense, will protect the joints and bones from some of the aches and pains from repetitive exercise. Now, having said all that, so the first thing you want to do if you're going to go walking is don't get too hung up on the surface you're walking, grass, gravel, asphalt, but make sure you have the appropriate shoe to accommodate your foot and ankle first. Number two, do a little strengthening exercise. Make sure your hip, your core, and your quad are strong. You do those two things, and I suspect the surface you walk on is less important. Now, having said that, you're right. Some surfaces are a little softer and have a little more give than others. But I wouldn't initially make the surface my first focus.
I was just wondering how we get to you. Do we just show up on Eckerman Road at your doorstep, or do we have to be referred by somebody?
So the question is, how do you get into OSU sports medicine? So you can go to centralized scheduling. You can ask for a particular physician. We have 10 orthopedic surgeons. We have 10 primary care sports medicine physicians, 83 physical therapists, and some strength conditioning people. I would encourage you to start off with a physician appointment. Unless you have a specific hip, knee, ankle, shoulder issue, you probably don't need to see an orthopedist. You can probably see one of our primary care sports medicine physicians. And they have backgrounds in family medicine, internal medicine, PM&R, and emergency medicine. And they will do a bit of a screen. They may even send you one of our, depending on what exercise you want to do. If you say, I want to start dancing, I want to start running, I want to start cycling, they may do a kind of a general medical exam, answer your questions, make sure you've addressed any medical issues you have. They may send you one of our therapists in those areas, and they'll do another little screen. Okay, before you start a cycling program, let's make sure your bike fits you, and bring your bike in. And, I've got this wrist soreness. Well, then if you're going to lean on the handlebars on a better bike, well, then let's change it to accommodate your sore wrist or your sore elbow, sore shoulder. So our therapist on a cycling program will customize that for you. So see a physician first to make sure you don't have any other issues, you don't want any cardiac or those type of things. Then they can customize your mechanics with the physical therapist. And then the therapist can even then outline a progression, say, gee, how do I start? Dr. Kading says start low, go slow. How do I do that? They can even write out for you a progression over 6 to 12 weeks to start to ramp you up. So did I answer your question on that? Yeah. So take advantage of that subspecialization.
Can you talk about plantar fasciitis, please?
So plantar fascia, can you picture the skeleton of a foot? You have an arch, right? So on what's called your medial ray behind your big toe, the arch is higher. Toward the lateral ray underneath your little toe, the arch is much less. And you have an arch there, and that's designed to absorb energy, right? It absorbs energy. It makes the foot have a little give to it when you walk. You've got this little spongy little arch. The plantar fascia is a soft tissue band that spans that bony arch, and they work together. I'm going to call it a ligament. You could argue whether that's a ligament or not, but where a ligament's attached to bone, that junction of ligament to bone or tendon to bone can cause pain. Tennis elbow is that way. Jumper's knee is that way. But now we're starting to see it more in runners in the common hamstring origin off the pelvis. So this is off the calcaneus, the heel bone. So you can get this overuse injury where this tendon or ligament comes off the heel bone underneath the arch of the foot. It can be very disabling, can be very painful. The advantage of any of those, they're called enthesopathies, is the fancy word we use for them. They do eventually go away. The problem is they may take 6, 9 months, a year and a half to go away, and most patients don't wait that long to get the tennis elbow or plantar fascia to go away. We don't always have an instant answer for them. Years ago, we used to go in there, patients are frustrated, make a little surgery, we actually cut it. And that got rid of the pain because now you're not longer pushing on it. But that arch lost that support, that little windlass support, and then some of those patients start getting stress fractures and bony problems. So you solve one, created another. Now, one thing about bone tendon junction, there's some evidence, not great evidence, that being low in vitamin D puts you at increased risk to develop those type of enthesopathies, tennis elbow, jumper's knee, plantar fasciitis. So if you've had a couple, yeah, I had tennis elbow, I had that too. No. Next time you see your family doc, your primary care provider, ask them to check your vitamin D. A high percentage of people in the Midwest have their vitamin D deficient. That's because, one, the sun doesn't really shine. Look out the window today, sun's not shining. The other thing is we've done a great job of telling each other, when you're out in the sun, put on your sunscreen, right? Don't damage your skin. Don't get skin cancer. Don't get wrinkly old skin because you're wearing the skin damage. Sun damage will be diminished by using sunscreen. Trouble with sunscreen blocks vitamin D synthesis in your skin. That's most of your vitamin D comes from the sun. So we're not in the sun because there's no sun out there. When we are in the sun, we slather on the sunscreen, so we're not getting enough vitamin D. So check the vitamin D level. Should be, they're going to say 35. I'd say over 40, and you can supplement that. The darker you're complected, the more sun you need. I hear some general concepts on plantar fasciitis, but different shoe wear, stretching the Achilles, because the Achilles attaches to one side of the heel bone, the plantar fascia on the other side of the heel bone, they're kind of connected. There are some things that can be done, but there's not a magic cure for that. There's some newer things we've used, everything from shockwave treatment. Now they're using a little bit of this 10X, it's an ultrasound device that can get in there and obliterate or vaporize some of the bad tissue and suck it out. But we don't have a magic cure for it.
I had a question about the maximum heart rate. It seems like my heart beats a bit faster. I know when I was about 20 years old, I calculated at one time about 240. It may not have been quite that high, but I couldn't imagine it being below 230 either. And I'm about 50 now, and when I'm riding my bike, I can get up to about 170, which seems a bit high for that calculation. So I was wanting to see if there was any problems I need to look out for, or that sort of thing.
So I think 220 minus your age is 170, so that's your maximum heart rate you should ever shoot for, and then you should shoot for 70-80% of that. So when you exercise, 70-80% of 170 is what, 140, 130? So that's the heart rate you should be looking for. So 70-80% of your max heart rate, which is 220 minus your age. Now, I'm not a cardiologist. You want to see one of my primary care sports medicine colleagues or cardiologists, they may want to obviously fine-tune that, or that's a general rule for the masses. You may be a little different. There's always that outlier. But, yeah, that fits.
I was wondering if you could provide more information on how exercise specifically helps decrease mortality in breast cancer as opposed to cancer in general.
I can't explain that. I just reviewed the literature on that, and it's out there, and it's widely accepted. You're right. It runs counter to our my understanding of cancer, but it's out there and it's been promoted. Good question, though. You know what? When you find out, email me. Let me know.
What do you do to stay in shape?
So, yeah. So, my challenge is the excuse of I'm too busy. That's the excuse I keep falling into, and I need to get. And I don't have a routine. Every day is a different day in my life. So that's my personal trials of I'm too busy and I don't have a routine that I can schedule in my exercise routine. So I'm trying to do more resistance work, a stationary bike, hiking, a treadmill on an incline, and in fact I leave in 2 weeks. I'm going to climb another mountain in Switzerland with some friends of mine. As I get older, the mountains seem to get steeper and taller. I don't know how many more I have in me, but we always keep telling each other we're not going to stop until we have to. But find something you enjoy, challenging. And usually if you do something with some friends, that's the key. If you can make it part of your social interaction. In fact, you saw on my slide there on, good health, and it's one of its social interaction. If you can couple your exercise regimen with some socialization, that's key. All right, guys, thanks a lot. Get out there. Steve, keep moving.